My name's Dr. Paul Wong. I'm the director of the Stanford Arrhythmia Service, and we'll be talking about atrial fibrillation, something of interest to all of us. So I'm very privileged to be the director or the leader in our group of this really outstanding, internationally recognized faculty. And so I've listed them here, and later I'll introduce the panelists who are here today. As you see on my left, we have a number of chairs, and that speaks to the format that we've come to really find very effective in these community talks. So what I'll be doing is I'll be giving a small, short slide presentation to give you an overview. The second thing I'll do is I'll have our panelists come up. I will have some questions for each of them, and we'll have kind of a Phil Donahue kind of an approach to interviewing our experts and hearing about what they do in their everyday practice and the kind of advice they might have for you. And we've allotted a substantial amount of time at the end of this session for your questions. And again, that's why we really want your to write them down and to give them to us. Okay, terrific. So I always start these talks with our mission statement or our pledge to you. And our mission statement is that we're dedicated to delivering outstanding and compassionate care to our patients while working with their physicians and advancing teaching and medical research in cardiac arrhythmias. We really take the trust that you and your physicians place in us very seriously. And our vision is to be one of the top centers in the country, delivering outstanding care and innovative care, translational research, and really outstanding service and access for our patients. So in the spectrum of all the things we do, there are a number of different procedures, a whole range of patients that we in fact treat on a daily basis. And that forms our daily practice that we're all involved in. But today, we're all going to focus on atrial fibrillation. So I'd like to start this discussion about addressing the first question. That is, what are the symptoms of atrial fibrillation? They may be quite varied. They may be palpitations, a racing heart sensation, a jumping out sensation in the heart. Or it may be something else like dizziness, loss of consciousness. It may also be shortness of breath or chest discomfort. Even fatigue or lack of energy may be the result of atrial fibrillation. So we're often asked, well, what causes atrial fibrillation? Well, I like to address this in a little different way, and that really is what precipitates or may trigger atrial fibrillation. And I listed a number of these. So some of the things that trigger atrial fibrillation include exhaustion and fatigue, dehydration, caffeine or alcohol, sleep abnormalities. Other things that can precipitate or trigger atrial fibrillation include stress, a procedure or surgery you might have, an overactive thyroid, or even stresses like exercise or elevation. So these are just some of the different things that we've identified that in fact may trigger some episodes. Now we recognize that not all episodes will have a distinguishable trigger like I've listed here. What is atrial fibrillation or AFib? It's a rapid heart rhythm of the upper heart chambers in which the electrical signal swirls around like a windstorm. When we describe atrial fibrillation, we're considering the most common heart rhythm problem that anyone has in the United States. Over 2 million people today have atrial fibrillation. It's associated with an increased risk of stroke and risk of death. When we look at atrial fibrillation, I'd like to present this graph. It shows in the dotted line the U.S. population. The green bars represent the distribution of patients with atrial fibrillation. And as you see, the majority of patients with atrial fibrillation are between ages 60 and 85 years of age. That's the sweet spot. And as you can imagine, as our population ages, therefore, the number of patients with atrial fibrillation is expected to dramatically increase over the next 2 decades. One point in terminology that will come up in our discussions is what's the difference between paroxysmal atrial fibrillation and persistent atrial fibrillation. So paroxysmal atrial fibrillation is atrial fibrillation that comes and goes on its own. Persistent atrial fibrillation requires some intervention, typically medications or an electrical shock, we call it electrical cardioversion, to bring the rhythm back to normal. Who is at risk for atrial fibrillation? We know, as we have discussed, that AF increases with age. Some patients may have a genetic predisposition for atrial fibrillation, and others may have a condition that may be associated with an increased risk of having atrial fibrillation. That may be hypertension, diabetes, metabolic syndrome, sleep disturbances like sleep apnea, an overactive thyroid, or even forms of heart disease such as cardiomyopathy or a prior heart attack. When we look at atrial fibrillation, and we said it is a condition affecting the upper chambers of the heart, the atrial rate, the upper chamber rate, is going very rapidly, perhaps 500 beats per minute or greater. The heart is like a two-story building. The atria are the upper chambers and the ventricles are the bottom chamber. And they're connected by a staircase called the AV node. And this prevents most of the beats from getting from the top to the bottom chamber, the ventricles. So very often we talk about the heart rate in atrial fibrillation. So we are referring to the rate in which the beats get to the lower chamber. So therefore it's the rate in the ventricles. The ventricular rate is what we call the pulse rate or the heart rate. So when we talk about ways to slow the rate, and this is what we call rate control, we talk about ways of decreasing the number of beats that get from the top to the bottom chambers. So we're going to use medications that specifically affect the AV node, the staircase connecting the top and bottom chambers. And these are medications you may be familiar with. They may include digoxin, beta blockers such as metoprolol, atenolol, propranolol, or calcium channel blockers such as verapamil or diltiazem. So these agents are used to slow the rate. They're not designed to convert the rhythm, but instead to slow the rate, the ventricular rate. And that often is all you need to do to make the patient feel much more comfortable in atrial fibrillation. What happens, though, if the patient remains symptomatic despite being in atrial fibrillation and having good rate control? We turn to another set of medications we call antiarrhythmic drugs. And so I've listed a number of here in the bottom in red, and they include flecainide or propafenone, sotalol or dofetilide, or amiodarone or dronedarone. These 6 agents are the medications that we use to maintain normal rhythm, to restore the heart rhythm back to normal. And so we may choose or advise patients to use one of these medicines over another based on a number of factors. That may be the presence of heart disease, artery problems in the heart, other issues such as decreased pumping function of the heart. Those are all factors that we'll use to individualize to each patient what might be best for them. One of the most important principles of treating atrial fibrillation that we really should never overlook is reduction of stroke risk. There's very good news about the ability to reduce the risk of stroke. And as you see in this graph here, you can see that compared to no treatment or placebo treatment in yellow, once you give an anticoagulant, in this graph, warfarin or Coumadin, it dramatically decreases the risk of stroke across the board in many, many groups of patients. So that's very good news. Recent data have led us to develop a scoring system called the CHADS-2 VAS score. And this is used based on a number of factors, each of which is giving a point score. And by doing so, adding up these scores, we can advise patients what is their risk. Is their risk higher or lower? And therefore, can we decide who should be on medications to prevent stroke in atrial fibrillation? And as I've indicated on the top, if you have a score of 0, current guidelines indicate no therapy. A score of 1 gives you your choice of 3 things, either no therapy, aspirin, or an anticoagulant. And a score of 2 or more, we recommend an anticoagulant be used to reduce the risk of stroke. Now, are there new treatments for atrial fibrillation in terms of anticoagulant choice? Yes. So a patient may be on warfarin, And we might advise them or offer them the opportunity of checking their level, their so-called INR, International Normalized Ratio, at home. There are now devices that are available, typically covered by most insurances, that allow you to do that. So the freedom of travel, returns, you don't have to worry about that, etc. Now, I've listed below 4 agents that are among the newer anticoagulants, and they include dabigatran or Pradaxa, rivaroxaban or Xarelto, apixaban or Eliquis, and edoxaban, which is Savesa. So these are some of the agents that are now new drugs to treat and prevent stroke and atrial fibrillation. And they do not require the same checking of the blood tests. They do not have the same drug or food interactions that we see with warfarin. So a lot of reasons why they're often selected and preferred by patients and physicians. So returning back to the question of treatment of atrial fibrillation, what are the different options? So we want to tell you about what catheter ablation is, since that will come up in our discussion further. So what do we mean by catheters? Catheters are small plastic tubes that we insert into the body, into the heart. And ablation refers to killing islands of cells that are responsible for the heart rhythm problem. So therefore, catheter ablation can be used as a way to treat patients that are symptomatic despite medications. And those symptoms may include shortness of breath, limitations of exertion, and other such symptoms. So how do we go about doing atrial fibrillation catheter ablation? So here I've illustrated the main paradigm that evolved in terms of the strategy to treat atrial fibrillation, because you'll hear a little bit about this in a few minutes. So how do we go about targeting atrial fibrillation with a catheter ablation? So there are structures called the pulmonary veins that connect the left atrium to the lungs. These appear to be particularly important triggers, sources of where atrial fibrillation come from. And I say it's like a match you throw into the fireplace. It may not be where the atrial fibrillation is, but it can act as a trigger and start the atrial fibrillation. So what are the different approaches? And so I've listed 3 here. The top 3 are the ones we are currently using, that is radiofrequency or cryo or freezing. So radiofrequency uses radio waves, and cryo is a freezing technique, both of which have been shown to be effective in treating atrial fibrillation. And then newer technologies, laser therapy, and that's in the process of being released. This slide shows the very first FDA trial results for radiofrequency ablation for the treatment of atrial fibrillation using catheters. And so you see here that compared to medicines, the use of radiofrequency ablation was much more successful. About 60% of patients at a little less than 1 year had freedom from atrial fibrillation. Cryoablation, freezing, is another technique that I mentioned to you that can also be used to treat atrial fibrillation. And very similar results were obtained in the very first FDA cryoablation study. Since then, for both radiofrequency and also cryoablation, the successes have continued to improve. This slide shows one of those examples where we see successes that are now reached the 70 and even 80% in some cases. More recently, there's been a trial. Its name is Fire and Ice, and it compared cryoablation and radiofrequency ablation. And looking at overall atrial fibrillation recurrence, it was roughly similar, about 65% freedom from atrial fibrillation. When we look at other factors such as cardiovascular rehospitalization as shown here, or the repeat ablation, there was a slight benefit to cryoablation, but roughly we think these 2 techniques are pretty similar. So how would we summarize things for catheter ablation? We would say that overall they're somewhat more risky than other forms of catheter ablation we perform, roughly 2 to 3% of serious complications. We think that for the patients that have paroxysmal atrial fibrillation, the majority have successes approaching 70 or 80%. There may be a need for a second procedure, and there's a lower success if you have persistent atrial fibrillation. There may be earlier recurrence of atrial fibrillation in the first 1 to 3 months, but that does not seem to as directly predict long-term recurrence. There may be some new arrhythmias called atrial tachycardias and atrial flutters. And as we've talked about, predictors of success include the absence of persistent atrial fibrillation. And for patients that have larger, that are called enlarged atria, the success decreases. What I've talked about so far have been the traditional approaches to catheter ablation of atrial fibrillation. Now, what are the new paradigms that have been developed? So this is a slide that Dr. Narayan, who will be up in our panel, will be talking about Alone to Me. And this is some of his early work. And as you see, it's a very beautiful map that he's created here for us. It looks like a map of the United States in many ways. But as you see here on the right panel, there's a little circle that's drawn. And that's designed to illustrate this truly innovative and new approach to treating atrial fibrillation, is to find a pattern that previously was not identified. And this is what we'll talk about next. As you see in the left-hand panel, there's a very great picture of a storm pattern, and you see that looks very much like what we're seeing in the atrium. It's a form of a storm, actually, in many ways. And this is, again, this procedure, which we call FIRM, that Dr. Narayan will tell us more about in terms of his work in developing and inventing this technique. This is a terrific little video on the left-hand screen. I think all of us can follow the little bouncing ball, the little red bouncing ball. That's what the computer is being able to allow us to see, that the human is not able to really conceptualize. But we can see that, I think, very easily visually, this bouncing ball in this very specific region or in this pattern that we call a rotor as a location from which atrial fibrillation is being generated. This has led to his work, which is first published here in this graph seen on the right-hand panel, which shows an improvement over conventional techniques. And this has further been extended now to multiple trials, which are ongoing to demonstrate this difference in success. So one other topic that I want to reintroduce again is that of really the spectrum of atrial fibrillation. So we talked about there's persistent atrial fibrillation, there's paroxysmal atrial fibrillation. Patients' atria could be normal size or can be enlarged. So there indeed is a spectrum. And one of the things we pride ourselves at Stanford is we really try to tailor our approach to each patient so that we have a solution that will really be designed to be suitable for everyone. And so as you can see from this, the most advanced typically presents the biggest challenge. In doing so, we will have different techniques that otherwise we might not use, but in fact may have great success. And so that might be FIRM mapping. And I'd also like to introduce another technology that we've helped to pioneer at Stanford called hybrid surgical catheter ablation. And this is a collaboration between our cardiac surgical colleagues and our group, electrophysiologists. And what the cardiac surgeon does, he uses small ports between the ribs on each side of the chest and then uses a small telescope to then be able to see the heart directly and use specially designed tools to ablate from the outside. So he or she's doing what we aim to do from the inside, but are in fact doing from the outside. There is a longer hospital stay because the need for the coming from the outside between the tubes, but between the chest ribs, but in fact it probably has a higher success than for a comparable technique. This is work that was from both the Netherlands and Virginia, which gives you an idea of some of the early published literature in terms of success, being roughly 70 to 80% in patients that had more advanced atrial fibrillation. The DEEP trial is an ongoing clinical trial that is designed to be the pivotal clinical trial for this approach that will ideally lead to FDA approval for this very specific indication. The technology has been approved for use in humans, but for this specific indication, that's the purpose of this trial. So how could we summarize what are the latest treatments? Well, there are many advances in atrial fibrillation catheter ablation. These include improved catheter cryoablation, improved radiofrequency ablation, new methods of mapping such as FIRM mapping, hybrid surgical and catheter ablation. There are other approaches such as mindfulness and its effect on atrial fibrillation, modifying risk factors to achieve better outcomes. So can I reduce the risk of atrial fibrillation? In some ways, can I prevent atrial fibrillation? And the data now are emerging that the answer is probably yes. Better treatment of hypertension, treatment of diabetes, metabolic syndrome, hyperlipidemia, weight loss in the treatment of obesity, identifying sleep apnea and its proper treatment, reducing stress, and eliminating or reducing smoking alcohol. Much of this work was pioneered by Professor Sanders in Australia, and as you can see, this includes weight management and exercise, treatment of hyperlipidemia, glucose tolerance, hypertension, sleep apnea, many of these factors which we've just mentioned. Based on the research that's been done to date, the impact can be truly profound. On the left-hand panel, you see without any drugs or ablation, a big difference. In the red line are patients that reduce their body mass by more than 10%. If you can achieve that, in this study, it showed that the results were far better than those who had no or minimal weight loss. Similarly, on the right panel, even with drugs or catheter ablation, the success is very different, meaning achieving these goals that we've talked about in terms of risk modification can even help the patient who's treated with medications and catheter ablation. That's true with either a single procedure or if you need to go on to have multiple procedures, the success is still enhanced by very aggressive treatment. So that's led us at Stanford to launch a new program that involves risk modification and also a mindfulness study. This is going to be led by Linda Ottoboni in our group. So finally, to conclude this talk, what are the take-home messages? What would I like you to leave today with? First, as you've heard about, rate control can be a very important step in improving symptoms and improving quality of life. We know that medications called anarrhythmic drugs or agents can be used to improve symptoms and decrease atrial fibrillation recurrence quite effectively. Catheter ablation may be very important in improving symptoms and recurrences in patients that remain symptomatic despite using antiarrhythmic agents. And anticoagulation has a critical role in reducing the risk of stroke. And finally, addressing a variety of factors like hypertension, diabetes, metabolic syndrome, obesity, sleep apnea, stress, and smoking may decrease the risk of atrial fibrillation. So in that, we'll conclude this first section. And again, thank you on the behalf of our service. And I'm going to ask, thank you very much. So I'm just going to ask our wonderful panelists to come up. And as they come up, I'll be introducing each one. I'd like to introduce Dr. Marco Perez. He's on the end here. In addition to be a very expert electrophysiologist, he runs our Inherited Arrhythmic Disorders Center. And he's a very internationally renowned researcher in this area. Angela is our lead nurse practitioner. She leads our entire advanced practice program and has written extensively. She's co-authored a textbook in arrhythmias, including atrial fibrillation. Chad Brott is here. He's a very experienced electrophysiologist as a member of our team. And Dr. Sanjeev Narayan, as I introduced already, is the inventor of firm mapping and really an internationally recognized expert as well. Okay, so I'm going to join them down here, and I'm going to go ahead and start. So I'm going to turn to Dr. Perez and ask him to describe to us what is atrial fibrillation? How do you describe it to your patients?
So atrial fibrillation, and you've already heard a little bit from Paul this morning, but atrial fibrillation is an electrical disorder that leads to a rapid, irregular heartbeat. Now, the way I like to think about it is, think of the heart like a pump, and like all pumps, it has its own electrical system. So this particular pump has several sections to it. The top part of the heart pumps blood to the bottom part of the heart, and the bottom part of the heart pumps blood to the rest of the body. And what happens is all of this is controlled by an electrical system. And what happens with atrial fibrillation is, especially as you get older and the top part of the heart starts to stretch and starts to get scarred, there can be electrical disorders at the top part of the heart. And as you saw in some of the slides earlier, these disorders lead to a very irregular activity at the top of the heart that often sends signals that go very, very quickly down to the bottom of the heart. And when your heart beats fast and irregularly, that can lead to the problems that we'll hear about with atrial fibrillation.
Great, thank you very much. I'd like to turn to Dr. Brott, and maybe he can tell us what are the symptoms of atrial fibrillation?
The most common symptom that we find people complain about is this sensation or awareness of their heart beating in their chest called palpitations. So it may be a racing, fast heartbeat, or the sensation that the heart is sort of flip-flopping, jumping around in the chest. So that's the most common thing people will feel. But otherwise, you might notice that you have shortness of breath that you otherwise wouldn't expect, particularly if you're doing your normal daily activities. You might get a chest discomfort. You might just feel fatigued or unwell, or that you're just not able to get through your daily activities the way you normally would. As mentioned in the video, there are episodes where you can become lightheaded, dizzy, or even feel that you might pass out.
Great, thank you very much. Dr. Narayan, can you describe to us who is at risk for atrial fibrillation?
So atrial fibrillation is a very, very common condition, and there are many risk factors. I want to first of all just quickly reassure people that if managed appropriately, many of the aspects of atrial fibrillation can be well controlled and risks can be reduced. But these are some of the risk factors that we know. We know that AF becomes more common with increasing age. You can certainly see people in their 20s and 30s with atrial fibrillation. We see them in clinic on a fairly regular basis, but it becomes particularly common after the age of 50, 60, 70 and beyond. We're not completely sure why. Some of that relates to the increased risk from high blood pressure, as Dr. Wong said, from other risk factors related to hormonal imbalance, such as a high thyroid gland function. Sometimes people who have other forms of heart disease, tightening of the heart valves, which is called stenosis. Sometimes regurgitation of those valves, or leakiness, which is called regurgitation, can be associated with it. Sometimes you have people who may have a little bit of chest pain and thickening of the heart arteries, or coronary disease may be at slightly increased risk. Occasionally we find that atrial fibrillation sort of runs in families, not in a traditional sense of mother going to daughter or father to son, but tends to run in a family. And some of those individuals have genetic causes that Dr. Perez studies in detail. So there are risk factors, but in general, we find that it affects people across a broad spectrum.
Great, thank you. Angela, can you describe what rate control is, and what medications do you use for rate control?
Rate control is the number of impulses that the AV node allows from the top chamber to the bottom chamber. And in the goal for rate control is around 80 to 110 beats per minute, depending on the activity. So what we usually use are medications that make that staircase that Dr. Wong described earlier between the top and the bottom chamber a little steeper and harder for the impulse to navigate. So it limits the number of impulses that come from top to bottom. So medications that are used for that are usually digoxin, a group of medications called beta blocker that includes metoprolol, atenolol, propranolol, and calcium channel blockers that include diltiazem and verapamil.
Great, thank you. Dr. Brott, would you tell us how do you use rhythm control? And particularly for rhythm control, what agents do you use for patients with normal hearts without any artery problems?
Right. So our first objective in atrial fibrillation, as Angela described, is to prevent the heart from going too fast. And if that were good enough and everybody felt well, we wouldn't have to do any more. Unfortunately, people continue to have symptoms, particularly very limiting symptoms, despite adequate rate control. And those patients, we would like to give you as much of freedom from this disease as possible. So we try to maintain a normal rhythm, meaning if you're paroxysmal going in and out of atrial fibrillation, we want to maintain you in a normal rhythm for as much of the time as possible. So as Dr. Wong sort of alluded to, there are a variety of medications that we can use. And the first agents that we typically use are flecainide and propafenone. These medications are particularly well tolerated. People take them and don't seem to be bothered by side effects from them. And they are been shown to be very safe and effective in people who have otherwise normal hearts. they don't have heart failure, they don't have significant valve problems, they haven't had prior heart attacks, which is what we tend to use as our first-line agents for this condition.
Terrific. Dr. Perez, what kinds of antiarrhythmic agents would you use in a patient who has either artery problems of the heart or decreased pumping function of the heart?
As Dr. Broad was talking about, there are different classes or different groups of medications that we have. There's some groups of medications, like the ones that Dr. Broad talked about, that are pretty safe in particularly young folks who don't have any other problems with their hearts. The problem is that when you do develop other problems with your heart, either heart weakening or problems with the arteries that go around the heart, then if you take one of these medications that Dr. Broad talked about, you are at slightly higher risk of having a dangerous heartbeat. So then we turn to a different class or a different group of medications. We call them class 3 medications. And those medications include dronedarone, amiodarone, sotalol, and dofetilide. And those are a little safer in patients who have other problems with their heart. And if you do have problems with your heart, then we can choose from one of those 4 medications, and we would individualize the treatment. Based on your particular heart problem, we would choose the type of medication.
Great, thank you. Dr. Narayan, when you use catheter ablation, do you use a certain number of medications before you recommend catheter ablation?
Thanks, Paul. So that's a really interesting and important question. At what point would any one of us recommend that a patient goes for catheter ablation as opposed to remaining on medications? There is no hard and fast rule on this, but most people would say that if you are doing well, if an individual is doing well on medications and symptoms are well controlled and there's no other untoward effect, that it's fine to stay on medications. Now, some people don't do so well on meds, or some people can't tolerate them, in which case we then consider ablation, which is a procedure that Dr. Wong mentioned, typically by ourselves will be done through the leg in a minimally invasive fashion. My personal decision and strategy is that I always ask people to try one medication for the reasons I've said. If they've got a fairly good relief, but it needs a little bit of a touch-up, I often would recommend they try a second medication. I have a couple that both Chad and Marco mentioned can be used very effectively. If at that point people still have symptoms or just cannot tolerate the medications, then I'll choose one or of many different types of ablation available. I think it's worth saying that there are actually some guidelines which are now emerging that for earlier forms of atrial fibrillation, as Dr. Wong mentioned, early forms of paroxysmal, it is possible and it is considered acceptable to go straight for ablation without medications, and rarely we may consider that in individual people. So the result is always tailored, but generally try 1 or 2 medications first.
Great, thank you very much. So our team at Stanford has either invented or developed or tested every major aspect of catheter ablation for atrial fibrillation. So we'll take a few minutes to talk about that further. I'm going to turn back to Dr. Narayan, who's inventor of the firm mapping technique. Could you tell us more about how the concept got created and what firm mapping is?
Sure. So mapping of atrial fibrillation is a way to find critical regions of the atria to target therapy. And firm mapping is one of those. It was the first to demonstrate consistently that regions of the top chambers may be driving AFib. So this is an important area because for many years we felt that AF is a sort of chaotic process. If it's chaotic, then really there's no specific region that's more important than another, in which case mapping may be less relevant. There have been studies for decades which have suggested that in some individuals there may be critical regions, and so firm was one approach that we developed over some time to look at very complicated signals that frankly I and my colleagues were having a really hard time figuring out, and using lessons from nature, ways that you interpret complex systems in biology or in physics to try and filter out noise and look at the signal And in that way, we were able to demonstrate what had been shown in experimental models, which was that in many patients, AFib had spinning tops that we now call rotational circuits or rotors, or little focal areas, a bit like a pulsar in the night sky that was driving the AFib, which we then tested by ablating those areas or just burning locally and showing that in some patients you could have a very dramatic effect. And that's how firm mapping developed. It was a company that's become commercial. There are now 6 others or 7 others actually in the space. And in many people it can be effective.
Great, thank you, Dr. Ryan. As I mentioned, it's really unusual that we have, the inventor of a new technology as part of a group, and we're very grateful for Dr. Ryan to be part of our group. So, Dr. Ryan, could you summarize for us what are the latest treatments for atrial fibrillation? Sure.
So there are many different approaches because this is a very active area of research around the world. So the treatments would include different forms of ablation, different forms of medication, and different forms of lifestyle. So I'll cover them very briefly, and we can go into more if we need to. So for ablation, I think there's been a dramatic uptake of this cryoablation approach, which Dr. Wong co-invented many years ago, whereby a balloon is inserted through the groin in a collapsed state, inserted into the atrium, then expanded so that in a single shot you can isolate the vein, which is a very common trigger site. There are many different types of balloon technology which are being developed. One is called a laser balloon, which is imminently available clinically. There's one called a radiofrequency balloon, and there are a few others which are coming. Those are very new and exciting areas. In terms of mapping, in addition to what I've just described, there are new mapping techniques. Some include the body surface to try and again find critical hotspots. There are other forms of catheters which are called baskets. A series of companies are working on those, which are again inserted in a collapsed state and then used to identify hotspots, which I think is a very, very central area of research at the current time. Hybrid ablation, or ways to really make sure that you're treating tissue in a very robust way, is a very actively growing area, and one that we do at Stanford with our surgical colleagues. Basically, one of the limitations of what we do from inside the heart is sometimes the ablation doesn't always hold. So by combining that with very limited surgical lesions, you can improve results. And there's a lot of different approaches to doing that and mapping. I think the medications have been covered, and I think it's really very important to state that lifestyle modifications can make a massive impact, and many people are incorporating those.
Great. Angela, would you describe how you handle anticoagulation before and after catheter ablation?
Anticoagulation is an important treatment that we offer our patients, or prevention from thromboembolic events and stroke. Before the ablation and cardioversion increase the risk for thromboembolic events and stroke in patients with atrial fibrillation. So we approach that very carefully. Not every single patient is on anticoagulation prior to the procedure, but every single patient will be anticoagulated after the procedure because of that risk. We generally anticoagulate patients for 2 to 3 months after the procedure, and then the long-term anticoagulation is dependent on other risk factors that the patients have. We call them a CHADS-VAS score. That includes other comorbidities such as hypertension, diabetes, coronary artery disease. Age is an important factor, previous stroke. Before the procedure, we generally, if patients are anticoagulated, the discontinuation of the anticoagulant or blood thinner prior to procedure depends on their stroke risk and their bleeding risk. Generally, anticoagulants are discontinued couple of days before the procedure. Some patients need to receive a medication called Lovenox for what we call bridging between the oral anticoagulant and the day of the procedure. So it really is individualized process on how we give and how we stop anticoagulant.
Great, thank you. Dr. Brock, would you describe what the risks are of catheter ablation?
Sure. So you've heard a lot about the idea of catheters getting into the heart, and how they get there is we have to go through the blood vessels where we start in the legs. We use multiple catheters to actually increase the safety and efficacy of how we do this procedure, including an ultrasound that allows us to directly visualize the inside of your heart. So this is how we can safely move things around. So in order to get there, we have to make little puncture sites in the legs to get into the veins. We stay on the vein side and get our catheters into the heart. So visually, you can sort of understand where those risks would come from. Bleeding, bruising from where we get into the veins in the legs is the most common thing we see. The blood vessels themselves do have risk of being injured. It's rare, but includes injury to those veins, the nearby arteries and nerves. Again, very rarely could require some surgery to repair or prolonged hospitalization to allow that to recover on its own. In addition, moving those catheters into the heart itself, there is risk of poking, damaging the heart muscle itself. If that occurs, sometimes there is a tear that requires repair. That could require a surgical repair. And again, thankfully, it's a very, very rare complication that occurs. The normal electrical system in your heart is always at risk of being injured and damaged as well. Again, unlikely to occur, but if that happens, sometimes pacemakers are required. The esophagus is a very important structure that sits right behind the top chamber of the heart. And in fact, it just likes to live exactly where we need to treat the majority of the time. So whether you're using freezing technology or the radiofrequency, which is sort of a heating technology, that esophagus gets in the way. We have lots of techniques and ways to protect the esophagus, but also to monitor how the esophagus is being affected by our ablation. But we do tell you that there is a risk that there could be a communication and injury to that esophagus. And in the early days in developing this technique, when it wasn't so well understood, that was a potentially fatal complication. I will tell you, to reassure you, we measure the temperature within that esophagus throughout the entire procedure. Most of us visualize it directly, so we know we're nowhere near it. And we have safe parameters that have been proven effective to avoid long-term injury. And as far as I know, I don't know that we've had one of those complications that I can tell you about. The heart itself, we're working on the left side of the heart. That side of the heart, because of the reasons we need to use blood thinners, is because it's in communication with the vital organs of your body, the brain and other important organs such as the heart. Blood clots can form on our catheters. They're not a part of your normal body, so your blood might think that this foreign invader needs to be blocked off and form some blood clots on it. We use blood thinners throughout the procedure so that doesn't happen, but there is always a risk that if those clots form, they could travel outside, causing stroke, heart attack, and in extreme examples, death.
Thank you. Angela, how can you reduce the risk of atrial fibrillation?
The way to reduce the risk of atrial fibrillation is to affect the risk factors that are involved in a development of atrial fibrillation, such as controlling the high blood pressure, hypertension, reducing the weight, reducing the risk of diabetes, treating sleep apnea, stopping smoking.
Thank you. So I'd like to turn to the topic of stroke reduction. As I mentioned, really one of the most important areas that we need to address with each patient. Dr. Perez, will you describe the risk factors for stroke of atrial fibrillation, and we describe the current scoring system that is used?
Sure. We've heard a lot already about how to control the atrial fibrillation and the rapid heart rates and trying to keep folks in the normal heartbeat. But I can't emphasize enough how important it is to try to prevent one of the most dramatic complications of atrial fibrillation, and that's stroke. And we spend a lot of our times talking to patients with atrial fibrillation about stroke reduction. So there are a few ways of treating patients with atrial fibrillation in order to prevent stroke, and we've heard about some of them already. But really the most important medications that we use are blood thinners And there are certain types of blood thinners that are a little bit stronger. The anticoagulant therapies is what we call them. But we don't give that to everybody with atrial fibrillation. So we really look for those who are at higher risk of having a stroke. One of the most important risk factors is age. So the older you get, the higher the risk. Once you cross a threshold of about 65 years of age, that adds to our point system. So we have a whole point system that's been studied very well in different groups of people with atrial fibrillation that give us a better idea of your stroke risk. So 65 is one point where you cross a certain threshold, and then 75 is another threshold where you get an additional point in this system. But there are other factors that we look at, whether or not you've had heart failure, in other words, weakening of your heart. If you have high blood pressure, that's another risk factor that gives you a point on this scale. Then there's diabetes, because diabetes has been shown to be a risk factor for atrial fibrillation. Another very important risk factor is the presence of a prior stroke. So if you have atrial fibrillation, once you've had a stroke, or even what sometimes people call a mini stroke or a TIA, then you are at much higher risk of having a stroke. And then there are other factors that more recently we've started to appreciate. One is whether or not you've had any problems with the blood vessels of your heart, particularly the arteries, especially those that go around the heart and down to your legs. And then if you're a woman, even though women in general are at lower risk of getting atrial fibrillation, once they have atrial fibrillation, they're at higher risk of having a stroke. So that also adds a point to our system. So we add up all the points, and based on your points, we might decide to use one of these stronger blood thinners.
Thank you. Angela, would you describe the period of time needed for anticoagulation before converting the rhythm back to normal? And also, what is transesophageal echocardiography and how is it used?
Before converting someone back to normal rhythm, we again take every precaution to make sure that the risk for stroke or thromboembolic events is reduced as much as possible. So if a person is in atrial fibrillation over 48 hours or of unknown duration, we need to do two things, or one of the two things. One, anticoagulate for at least 4 weeks prior to procedure, and that a little bit depends on which medication a person is, or offer a procedure called transesophageal echocardiogram. As it was described previously, esophagus or food pipe is located right behind the left atrium or top chamber of the heart. And it turns out that that's where the blood clots usually form. So we need to be able to look at that part of the heart and make sure there is no blood clot. We do that with the procedure called transesophageal echocardiogram. In other words, we put a camera inside the esophagus, and by the way, that's all done under the sedation, so patients don't usually feel it or know that we're doing it. So the camera is placed in the esophagus, and the camera looks directly into the left atrium. And that is the way to visualize whether there is a blood clot there or not. If there is no blood clot, then we can either start medications that control the rhythm or perform a procedure that is called cardioversion to convert the rhythm.
Thank you. Dr. Brott, would you describe the alternatives to warfarin and how you might select the anticoagulant of choice?
So warfarin, many people tend to know pretty well because it's been around a long time. It's otherwise referred to as rat poison. So you take this medication, it actually works within the liver, and it interferes with the process of creating important factors within your bloodstream that are necessary for forming clots. So it's been very valuable to protect people, prevent strokes for a very long time. The challenges are because it requires a process of metabolizing in your liver, there are a lot of things that interfere with that process, including medications you take, what your diet is. Because there's so much variability, in order to make sure you're safe and protected, you're not going to have too much on board and cause bleeding or not have enough and prevent stroke, we have to check it very frequently. Routinely, you have to get this INR check. So any of those things are very, not advantageous to you and your busy lifestyles to get through a day-to-day. You've got to plan around your INR checks. You have to plan when you're going to have kale, how often you're going to have it, and change your dietary lifestyle that way. So these new agents have been created that sort of get around the metabolic process in your liver, and they go directly to how blood clotting occurs in the bloodstream. So these new drugs were direct inhibitors of the clotting process. So this frees patients up from having to worry about getting frequent blood tests. You don't have to worry about changing your diet. If you want to eat a big salad today and not for 3 weeks, you can do that. These agents, the 4 that were mentioned in the presentation earlier, I'm going to use trade names because people tend to understand trade names pretty well, but you have Pradaxa, you have Xarelto, you have Eliquis, and you have Savesa. I like these medications particularly because they're good for you in terms of giving you some lifestyle back. But in addition, they have all been tested against warfarin. And they've all been shown to be at least as good as warfarin. In some instances, they've actually been shown to have improved efficacy preventing against stroke, but also improved effects of having less bleeding complications compared to warfarin. And because they are directly impacting how blood clotting occurs, we just feel safer knowing that you are going to be protected. As long as you take the medication as prescribed, you're going to be protected from stroke.
Great, thank you. Dr. Narayan, what are the techniques to close the left atrial appendage? What is the role of that, and how would you select patients for that procedure?
Super, thank you. This is a very interesting and emerging field that's become quite widespread. The basic notion is that in the heart that Dr. Wong showed you pictures of, there's a little area, a bit like a dog ear, that's called the left atrial appendage. It's floppy. In some people it's extremely big, quite long, and if you can imagine the heart beating and quivering at many hundred beats a minute, then in some people there's a risk for blood to become stagnant and clot. And that appendage is often one of the areas. It's not the only area, but it's one of the major areas. So as Dr. Wong alluded to, closing it off is one form of therapy. There are basically 3 ways to do that. One is from inside the heart, much as you would do an electrophysiological ablation procedure, often through the legs. The other is a combination with an approach where we would make a small, minimal hole, not even an incision, a tiny little hole from outside the heart, and close it from a combination of in and out. And the third way is if one is already having a heart procedure or operation of any kind, the appendage could be closed off. So the areas, the techniques that are becoming particularly common are going in through the leg and then closing this off. And the way that's done is to go in, all blood vessels lead to the heart, cross from the right to the left side to get to this dog ear, this appendage, and then insert a device. The commonest one that's being used currently is called the Watchman. I think there's the greatest worldwide experience of that particular device, and the success rates in experience centers are very good. People who have the appendage closed off in that way can, after an initial period, potentially stop their blood thinning medications, warfarin or one of the newer ones that Chad mentioned. There are other emerging devices to also close off the whole of that appendage. The alternative approach, which is used a bit less often, it's still actually approved for use, is the combination. And in that procedure, one would make a small needle stick, pass a little wire just outside the heart in a thin sort of sac that the heart lies in, and then put a snare around the appendage and tie it off. It's quite clever. That also has got some data to support it. Some people end up having chest pain afterwards, and as I said, the internal closure is the most common. Overall, who would be warranted? At the current time, we recommend these procedures for people who cannot tolerate blood thinning medications. There are many reasons for that. One might be that they bleed a lot when they're on one of those blood thinners, and that's at the current time. However, this is an emerging area, and as we move forwards, I think you'll see studies supporting the use of this more and more in selected people.
Great, thank you. So we finished our panel discussion time. Hope you found that was enjoyable. Thank you. Great. So we're approaching the final part, and this is, I think, the most fun part of the whole, morning. As you can tell, we love talking to patients and fielding your questions. So I'm going to ask Dr. Narayan to be my timekeeper, so we stay on time. He's going to be my taskmaster here. We've got a lot of questions, so you've done a great job out there. So keep them coming. Keep the questions coming. So I'll take some of these, but most of these will be for my colleagues. Are there any long-term effects of Class 1C agents, propafenone or flecainide? Dr. Brott, do you want to take that one?
So when you mention long-term effects, I presume you're concerned with injury to organs or some sort of toxicities long-term. Most people come into this world and come into these sort of conferences having heard a little bit or maybe a lot about AFib, and amiodarone is a common drug that gets mentioned. It's a very powerful, effective drug, but we know that there are a lot of concerns with it because taken over a long period of time, it can deposit in various organs such as the eyes, the thyroid, the lungs, and the liver. And so we're always monitoring for those changes. Flecainide and propafenone, one of the main reasons why we use this up front as a primary drug that we go to is that there aren't any of those concerns. We do not have to worry about cumulative toxicity over time. I think the biggest long-term concern we have, and if you're already on these drugs or you've been on them in the past, you know that your doctors will get routine echocardiograms to check the function of your heart, and they'll maybe do a stress test every couple years to make sure you don't have coronary artery disease. And the reason why that is these specific drugs were used in people who had heart problems in the past, who had heart attacks, and it did show that it increased their risk of death. And so we have to be very vigilant to make sure that things don't evolve in you that change your risk profile while on these medications. But the medications themselves are not toxic and do not require any additional monitoring beyond that. We'll check your kidney function and things of that nature, again, just to make sure you're not having a change that would change how you process the drug, but otherwise they're not harmful long term.
Okay, so I'm going to ask my faculty to keep the answers short,
sorry.
maybe 30 seconns or so, because we got a lot to go through. Okay, so here we go. Sorry, Chad. Okay, so for paroxysmal AFib, I'll give this to Dr. Perez. For paroxysmal AFib, is the long-term health of the heart improved with earlier ablation?
That's actually a very important question. It's one that's being debated right now. So we don't know the answer to that yet, but there are some clinical trials right now to see if earlier ablation has better long-term reduction of atrial fibrillation. So we'll have a better idea in a few years.
Great. Angela, can you explain cardioversion? How does it work? How is it done? How successful?
It's a very good question since I do it every day. So cardioversion is a way to convert the heart back to normal rhythm or reset the heart electrical system. The way we do it is we make sure our patient is safe from the stroke risk perspective. In other words, that they're anticoagulated appropriately before they come for this procedure. Then we evaluate the patient, explain the procedure to our patient, make sure they understand what's going on. We place pads on the chest and the back. We sedate the patient, and then we deliver an electrical shock that essentially stops the heart electrical system, allowing normal conduction to come back. This procedure is done under sedation. Patients are asleep. They don't feel it. There are no lasting side effects of this procedure. They generally can go home and resume their activities the next day, essentially.
Great. Dr. Perez, difference between atrial flutter and atrial fibrillation. Does atrial fibrillation generally develop into atrial flutter?
Yeah, so we often see patients who have both atrial fibrillation and atrial flutter. Atrial fibrillation, as we've talked about today, is a much more disorganized electrical disorder at the top of the heart. Dr. Narayan has talked a little bit about electrical storms or rotors. Atrial flutter has a much more organized system behind it. There's an electrical circuit that goes around and around a line that's already present in your heart, and that can go around at a very fast heart rate and cause your heart to beat faster.
Great, thanks. I'll take a couple of these. Difference between antiarrhythmic meds and beta blockers. So antiarrhythmic agents are to maintain and restore normal rhythm. Beta blockers are for rate. What are the greatest intolerance to beta blockers? So slowing of the heart rate, it can lower the blood pressure, little fatigue, those are some of the things. When is it considered a med to be a failure? So that's really based on symptoms, generally speaking. Okay, do you still have frequent episodes, that kind of thing. So it's a little more of a broader question. Okay, I'm going to throw this to any faculty member who wants this. Can one of the panelists talk about the vein structures relating to the success or failure? I'm not sure what that exactly means. Dr. Narayan, do you want to take that?
Sure. So, one of the main targets for ablation is the pulmonary veins. There are typically 4, 2 left and 2 right. And the goal is to draw an electrical barrier around those veins. That's sometimes done with a catheter moving it meticulously, point to point, and sometimes it's done with one of these single shot balloons. There are certain veins where that becomes more difficult. If you have the 2 vein, let's say the 2 left, that don't come off as 2 separate branches, but off a common branch, the common branch can be very big. And that can be very, very difficult to isolate with a single shot. So if you go in ahead of time, if one of us goes in and doesn't know that, or it's difficult to get the orientation, that can be more difficult. Does that prevent you having an ablation? No. There are certain other variations like that that can make a procedure more or less effective.
Great. Dr. Brott, when are pacemakers recommended?
In regards to atrial fibrillation, this is something that's changed over time. We don't usually use an approach with pacemakers to treat atrial fibrillation. But many of the drugs that you may be on to treat your atrial fibrillation will slow your heart rate unnecessarily. If you're symptomatic from that, but you need the medications anyway, then we'll recommend a pacemaker. There is a very advanced sort of end-stage approach that we'll take where we use pacemakers, where no matter what we do, we can't control your heart rate. The drugs aren't working, maybe catheter ablations failed, and so in those circumstances, sometimes we'll disconnect that staircase, that connection, that AV node between the upper and lower chambers, which will require a pacemaker to give you the heart rate you need thereon. So there's sort of 2 different reasons why we can use pacemakers.
Okay. I'll throw this to anybody. Any correlation between hemochromatosis and AFib? Anybody want to comment? Dr. Perez, you want to try that one?
So there certainly are case series, in other words, groups of patients with hemochromatosis who have atrial fibrillation. Hemochromatosis is not common enough for us to appreciate really to have a very good understanding of how often atrial fibrillation is, but there certainly are collections of patients with that disorder who have more atrial fibrillation.
Okay, great. So Dr. Perez, can leg DVT in the past increase the risk for AFib later in life?
Usually, when you have DVTs in your legs, that often is associated with certain risk factors that overlap with atrial fibrillation, like obesity, like diabetes, like high blood pressure. So it's not that the DVT itself is causing the atrial fibrillation, but that you have certain risk factors that gave you the DVT, but also place you at higher risk of having atrial fibrillation.
Okay, great. I'll take a few of these. What are CHF or left ventricular dysfunction? So left ventricular dysfunction is a decreased pumping function typically. CHF is a general term of typically fluid accumulation, etc. So that's that. Another question is, used to be told symptoms of heart attack or stroke include shortness of breath, perspiring, dizziness, vomiting, pain in the chest. Do all these symptoms have to be present at the same time or just a few? So I think that refers to heart attack, I guess. So you can have any number of symptoms, etc. The next question is long-term effect of flecainide. They take 150 milligrams twice a day, and I'm 50 years old, maybe taking for 30 or 40 years. As far as I'm aware, there's no known long-term effects.
Except the need to screen for coronary disease. Except that individual should screen every 1 to 2 years for the development of coronary disease.
Okay. The standard cardioversion procedure requires 4 to 6 weeks of blood thinners. Does FIRM require any pre or post procedure that includes blood thinners?
No, the procedure is done, planning is pretty much the same as for any ablation.
Mm-hmm. What is the home recovery period? I can take that quickly. So generally people up and around, typically in the next few days, little discomfort in the groin. We tell people not to exercise or lift objects for 1 or 2 weeks. I'll take this too. Are you put asleep during ablation? If not, are you aware of what's going on? So it can be done either way. I think most of our practice is to use general anesthesia, but certainly it's not obligatory necessarily. Does age matter in choice of treatment? I could take that. I think generally not. I think it's much more commonly it's the comorbidities, the overall state and health of the patient rather than a specific age. Going into higher altitude a factor, how high? Anybody want to take that? You have a cutoff in terms of that? I could just comment, I think altitude is a stress. So if you're going to exercise and have altitude, particularly when you're not accustomed to it, I think that definitely could be a precipitant. Anybody want? Okay, good. If I have a successful catheter ablation, does that mean I can never experience atrial fibrillation again? Okay, Dr. Perez, you want to take that one? Yeah.
So these ablations have been around for over a decade. So we have a pretty good sense of, at least within that time period, what the success rates are. And overall, depending on how much atrial fibrillation you started with, if your atrial fibrillation comes and goes, the success rates hover around 60 to 80% within those 5 to 10 years. The long-term effects, we don't have a good idea of yet, but we do know that heart tissue does regrow, and so our theory is that over a long period of time, a lot of folks will have recurrence. That being said, there's some who've had one ablation and never have it again.
Good. So I'll take this. How common are steam pops in RF ablation, and how is the risk mitigated? So steam, when we deliver radiofrequency energy, the tissue heats somewhat, but typically not to the level of causing steam. So it's a matter of regulating the amount of energy, so we try to be conservative and not have that happen.
New catheters and monitoring techniques, we don't see that.
Improve that significantly, yeah, absolutely. Atrial fibrillation appears to treat a symptom rather than the cause of atrial fibrillation. Does this mean a patient will always have sensitivity to triggers such as stress, alcohol, and caffeine? Very good question. So I'll take that. So not necessarily. If you have a successful antiarrhythmic agent or catheter ablation, you may not develop those with triggers. Anybody want to comment? Overlap of AFib and aortic stenosis. So I'll take that. So mitral valve disease is very closely related to atrial fibrillation, but aortic valve disease has some relationship as well. Is there a screening test to see if one is susceptible or have an initial stage? I think that implies before you have it. Now, one of the things that we do know is that monitoring is developed, progressed, and so people might not know they have atrial fibrillation, so monitoring may pick that up. That's most useful when someone has had a stroke that's unexplained. You can even have an implantable monitor that lasts several years in terms of that.
So there have been some data. This is also a very hot area. If on a ECG you see lots of frequent extra beats, single beats, that may be a risk factor. The other things discussed, like uncontrolled high blood pressure, high weight, those things can also be risk factors.
Great. How do you select which medicines use beta blockers or calcium channel blockers? For most patients, they're roughly equivalent. Obviously, if you have asthma or something like that, you wouldn't use a beta blocker, but they often can be used interchangeably. Now, I'll throw this one out to anybody. Please discuss Dr. Weil's mindfulness, breathing exercise, 478. Anybody know about that? No. So what we can say is that there have been some studies underway. They're pretty preliminary. What the impact of mindfulness, one of our nurses, Linda Ottoboni, is doing such a study. There's been work on yoga of reducing atrial fibrillation. When you become aware of a start of atrial fibrillation, what can you do to shorten or stop the episode? That's probably pretty individual, whether just relaxing, taking extra, breathing, et cetera, will actually stop it. There are reports of people exercising and stopping. I have patients that works on, but that doesn't work for most people. Certain medications, again, you can discuss that with your doctor. Watchman procedure, Dr. Narayan talked about that, closure of the left atrial appendage. Laser ablation, we mentioned, is one of the balloon strategies, and that's what we talked about. Okay, on the maternal side of my family, there are many heart issues, stroke, fatal heart attack, AFib. What does this predisposition mean to me and my children? Dr. Perez.
If you look around the room right now, you'll see that most folks are a little bit older, but there are a few young faces. And we do know that although the vast majority of patients with atrial fibrillation are older, you can get atrial fibrillation even when you're a teenager or in your young adult life. And that usually signifies that there's a connection there due to a genetic abnormality. And when you start seeing atrial fibrillation in other family members, there may be a genetic connection. And that's usually in families where atrial fibrillation happens at a very young age. But because a lot of people develop atrial fibrillation when they're older, just because there's somebody older in your family who gets atrial fibrillation does not necessarily mean that you are going to get it.
Great, thanks. If someone is regularly in first-degree AV block, does that impact the treatment options? So I'll take that. So that means that the conduction time from the atrial ventricle is a little prolonged. Its impact is mainly that certain medications like beta blockers and calcium channel blockers have to be used with greater caution in impairing function. Okay, after 90 days, do some patients have complete absence of AFib? Yes. What percentage have some? So that's variable based on your persistent or paroxysmal. How do you select an EP to do ablation? How do you tell if they're qualified? Tougher decision, really. I mean, obviously you go based on recommendations of people you know, things like that, people who have had experience, etc. Is there any procedure to cure AFib that does not require blood thinners? Okay, I can take that. So the current practice is that we use the CHADS-2 VAS scoring system. So what your risk is overall, whether you stop the anticoagulant after the 2 to 3 months. I have myeloma and cannot risk lowering my already low platelets. Yes. So that is a concern. I suppose the issue is if someone can't take anticoagulation, would you do catheter ablation? I think most of us probably would not. There are surgical treatments that don't go inside the heart. If you're not in AFib all the time, that might be an option, so that would be an example.
But depending on the platelet count, it might not be a complete contraindication. So it's worth checking with your physician to see, or maybe getting a second opinion to see if somebody's willing to do it. The blood thinners don't necessarily drop platelets.
So do different healthcare organizations use different treatment approaches to treating AFib? Yeah, that's even from physician to physician. They may have different approaches. I think the question is, does it really matter which approach? That's difficult to say, I think. We generally say, go to somebody who does this regularly and use the approach they do most often. There's been a mention of medications that reduce the electrical impulse setting to the ventricles. What is the danger of these impulses? Oh, okay, so usually we're not too concerned about how many beats go to the ventricle. That's more of a comfort thing, but certainly when it gets very rapid, you can have passing out, things like that. So we wouldn't want it to be too rapid. What percentage, why the high percentage of patient needing a second ablation? We may not be able to identify the areas, so kind of related to firm mapping, that may help us identify certain areas.
And sometimes lesions you put with a catheter recover over time.
Great. I have been hospitalized twice due to the use of blood thinner. What else can I do to prevent correction? Okay. Yes, it's difficult. I think there's a risk. Luckily, we have reversal agents for some of the agents, and then there would be reversal agents coming. What are long-term monitoring strategies besides taking medications? So we generally rely on symptoms more than necessarily intensive monitoring to guide therapy. What approaches might be recommended for a person experiencing AFib only while exercising heavily? This person otherwise has no significant exercise issues. That's a tough one because many people, like to be very exercise heavily. It can be challenging. We generally probably recommend medications or catheter ablation for those individuals. Can you talk about the risks of anticoagulants? A number of the agents have numerous lawsuits pending major bleeding. So I think we generally think that the risk-benefit is far outweighs, in terms of that. We recommend anticoagulation. What is the success rate in atrial fibrillation? How soon does it need to be repeated? And how many times can you have it? Can ablation be partially successful? So I'd say ablation definitely can be partially successful. You can reduce the number, they can be less severe, et cetera. People can have 3 or 4 ablations, certainly. If you have had cardiac conversion that lasted only 5 days, then things were the same again. Would you recommend it trying again? Yes, so you could try a different medication. You may not have been on a medication before. Totally worth doing. And then you could discuss catheter ablation. I'm 63-year-old male, mechanical heart valve, aortic, take warfarin, metoprolol, flecainide. Are there new drugs or treatments? Yes, there are newer drugs than flecainide, but that doesn't mean they're necessarily better for you. So if you're doing well, you should generally stay on it. Yesterday, I noticed an odd sensation, mild, noticeable discomfort below my shoulder blade, back, right side behind the ribs. It remained for several hours puzzled. It isn't evident today what may have been going on. Discomforts are hard to definitely pin down. We never really know. Generally, they merit talking to your physician. I've been diagnosed with low atrial fibrillation. I'm taking 120 diltiazem. I hardly have any atrial fibrillation. I'm 69, borderline hypertension, very good cholesterol. I've been told that I should be substituting the aspirin I have with everyday stronger anticoagulant. Aspirin is essentially, I guess, the same as anticoagulant. So we would use the CHADS-2 VAS scoring system. The 69-year-old male would have a score of 1, borderline, I guess. So the question is, how borderline? Yeah, so if you call it hypertension, you would meet 2 and you would require anticoagulation. Drugs generally have side effects. Why not have the ablation eliminate drug therapy? So we give that patients the choice. That if you prefer ablation over medications, you're given that choice based on current guidelines. The longer it goes, the less treatable. Yes, no. It's more difficult to treat, generally. Success is lower for antiarrhythmic drug therapy and catheter ablation. Why use warfarin today? Many patients are already on warfarin, so they prefer that. Some for patients, it's cost. They'd rather do that. Is there an antidote for apixaban? It's coming within 12 months, hopefully. Do you have experience treating patients with apical hypertrophic cardiomyopathy with atrial fibrillation? Dr. Perez? Yes.
Yeah, so at Stanford, we actually have a pretty large hypertrophic cardiomyopathy center. And about a quarter of patients with HCM, or hypertrophic cardiomyopathy, do develop atrial fibrillation. So we do have a fair amount of experience treating those patients.
Okay. And so the additional is, after ablation, what success rate? I think it's somewhat lower than that for people without hypertrophic cardiomyopathy. Okay. If you're taking a blood thinner such as Xarelto, does the bridge Lovenox medication requiring preparation for surgery? That's variable in practice. So some people will not bridge. They'll simply just stop the Xarelto and go to surgery. Other people that are felt to be higher risk may be offered bridging. Is there lifestyle methods to prevent atrial fibrillation? We've talked about some of them. Certainly, reducing smoking or limiting smoking, weight loss, etc. What are the criteria for AFib surgery? So we discuss the hybrid procedure for patients that have, for example, failed catheter ablation, etc. Does mitral regurgitation increase the risk? Yes, it does. Presumably in stretching the atria, there's more volume going and higher pressure. I've been taking aspirin as preventive therapy. I've heard often that after 50, the benefit of aspirin is longer there. Is it time? So we use the CHADS VAS scoring system, so based on your score. How does AFib affect life expectancy in the relation between AFib, heart failure, which causes what is a relationship? Yes, so AFib can worsen heart failure can produce AFib, and there's a complex relationship with life expectancy.
Yeah, small but measurable effect.
Yeah. Firm or hybrid surgical, so those are important techniques. Are there drugs similar to Eliquis but at a lower cost? The cost often depends on your insurance, so we kind of look at them, they're pretty similar to us, but one is covered by your insurance, one is not. Can catheter ablation clear permanent AFib, meaning long-standing? Yes, it can. The successes are lower, but definitely can in some patients, certain percentage. Please compare cryo versus RF for permanent AFib. As we kind of mentioned, most of the techniques are centered around the pulmonary veins. They're probably not adequate in many people to treat permanent AFib, and you may need other, whether it be fur mapping, hybrid surgical catheter, more extensive ablation. Do we have an East-based center we can go to? There are a number of affiliated practices, not us personally, that work in that area. How do you decide which anticoagulant to use? So there are a number of factors. Sometimes it is cost, but in general, most of the agents are more similar than different. When do you have to go to the ER when having an episode of AFib? Yeah, that's tough. So when you're uncomfortable, if you're having really significant symptoms, chest pain, continuing shortness of breath, generally you need to seek medical attention. 84, yes, no, RE ablation, etc. So is that too old? I think we've all treated people in their 80s, so it's based on your overall condition and your goals, etc. Question, correlation between AFib and Alzheimer's. Yes, there's been some preliminary work suggesting that Alzheimer's may be higher in incidence, but that's very, very preliminary research. After a successful hybrid or Cox mini maze, my heart resting is significantly higher. Would it ever become lower? Some people believe, as I do, that's a sign of something good that's happened, so you're on the good side. Is it okay to exercise while AFib is occurring? That you're going to have to discuss with your physician. Generally, we tell people to kind of take it easy. If one doesn't feel any symptoms but only feel the heart, should one worry about it? None of the risk factors, etc. So yes, so still talk about stroke reduction, etc., and talk to your physician about managing. But indeed, symptoms are the biggest thing. When is it considered persistent, etc., several times a week? No, if it goes back and forth, we don't call it persistent. Do any of us have AFib? Anybody want to fess up? No, okay. All right. I don't ask them. I can't ask them, so I don't know. It's a good question. Is ablation recommended for asymptomatic permanent AFib, heart rate 80? So not usually. Ablation is really reserved for people who have impaired function. 2 minutes. Okay, good. How invasive is laser treatment? It's like other treatments of atrial fibrillation. It's catheter-based. I understand how beta blockers block the pulses from going through the AV node, but the atrium is beating fast. Is that a problem? Is there the long-term effects? That's a complicated question. So we mainly focus on the rate, ventricular rate, but yes, in the atrial fibrillation, it's still going fast, and you can have symptoms related to that. When I feel angry and mistreated and work too hard, I feel cold. Is that a symptom of AFib? Difficult to know. AFib is difficult to say. Can you briefly talk about the pros and cons of each anticoagulant, Pradaxis, Relto, Eliquis, Savesa? So there are some differences in whether they're once a day, twice a day. Pradaxa has currently a reversal agent. The others are waiting. So some are renally excreted more than others by the kidneys. Why does hyperthyroidism cause AFib? Is it because of a calcium load? I don't think it's really the calcium, but it has a stimulatory process. What occurs at once a month? What should I be doing to keep my job? Medication at onset of AFib. I have 2 stents. So you'll have to talk to your physician. There may be medication strategies you can do, and then you can reduce it. Can a stroke be reversed? So as you know, stroke is viewed as an emergency like heart attack. You call 911, and almost every medical center has a way to acutely treat stroke. So thank you very much. I want to applaud our panel. They've been terrific. I hope you found this enjoyable and educational, and please remember to give us your comments. We really value them. So thank you. Have a great day.
Thank you.